We'll go and get started on chapter 21. This is over endocrine and hematologic emergencies. I know those can be scary words for paramedics and EMTs, but we'll talk about it. We really don't have to know a whole lot about this. In the grand scheme of things, there's a lot to be said about. I mean, there's entire specialties dedicated to this in medicine, but we only need to know really kind of the emergencies and what we'll likely encounter. Endocrine cell, the endocrine system itself will influence every cell, organ, and body function, right? So it's very it's in charge of regulation of the body, homeostasis. So there's a big role with the endocrine system. And so, as you can imagine, there's a lot that can go wrong. And if one piece of the endocrine system malfunctions, it tends to be systemic and body wide that you notice all these manifestations. So that's kind of where the complications come in. And this is why they can tend to be emergencies. Because, for example, when the thyroid quits working, or it works too much, or the pancreas works too much or works too little, then the whole body gets jacked up. So we'll talk about that. But and then the hematologic, this is relating to like blood disorders like hemophilia, sickle cell disease. We'll talk about what these are. These are fairly rare, but they occasionally show up on tests, so we do need to know what they are. And we do see these. I mean, there are real patients you'll encounter in your career that have sickle cell disease or hemophilia. So we'll talk about that. But the majority of this text will focus on endocrine. So, the endocrine system, network of glands that produce and secrete chemical messengers called hormones. Or, hormones are like, testosterone, estrogen. There's a lot of and then there's hormone digestive, what they would call hormones, but they're not true hormones. Like pepsinogen and trypsinogen and CCK and all these other hormones and things and messengers that we use. And so we'll just zoom in and review some quick anatomy. So the pineal gland has to do with sleep. So if you've ever heard of someone taking melatonin for sleep, that's where it's produced, right? Normally. And so that's a little bitty gland that's located in the center of the brain that produces melatonin. So it has to do with sleep regulation. Now, the pituitary gland, we're going to talk about a lot because there's a lot of stuff that comes from this itty bitty organ that's about the size of a pea located up in the head. So let's just look at it over here real quick. So this is the pituitary gland. It almost looks like a set of testicles or something, but it's about the size of a pea. It's very, very small. And so it sits in this little groove called the sella turcica. And so this is right behind this. This is like the sphenoid, right? So it's like right up in the nose at the base of the brain. And so, like, for example, if this is so small, if you were to take someone's brain out of their head, like in a cadaver lab or something, the pituitary will sever and it'll stay in this sella turcica because it's that small and this stalk is actually especially thin. And there's pathology we'll talk about in head trauma where this gets severed, called diabetes insipidus and SIADH. But we'll talk about that later. But so what we need to know about the pituitary gland's anatomy is that there's a lot of sensory information coming through the thalamus. The thalamus does a lot of like sensory and regulatory functions, but the hypothalamus, meaning below the thalamus, it does a lot of precursor chemicals, right? So like it'll send a chemical down to so it'll create a chemical that'll tell the pituitary itself, hey, make this hormone, make this substance. And so, there's a certain hormone here, and then there's another hormone that's created there, and so it's kind of complicated. But what happens is it'll travel down the stalk, that hormone, and that's in the anterior pituitary. But the posterior pituitary, you don't need the difference between the two. I'll just give an example. Is the hypothalamus will actually produce stuff like oxytocin, and it's sent down to the pituitary for storage. So what am I saying? Well, the pituitary can actually do it can produce hormones in the anterior pituitary, and it can also store hormones in the posterior pituitary. So it kind of has like this really important hormone role. And as you can imagine, if this gets cancer or gets squished on or whatever the scenario is, doesn't get enough blood supply, like in Sheehan syndrome or something like that, it creates a whole list of issues for the patient. So that's kind of what I need y'all to know about that. We'll keep talking about some real quick anatomy review. Okay, so the thyroid sits up here in the neck, and on a normal person, you can't, quote, feel this, right? You can feel the cartilage, the cricothyroid cartilage, but you wouldn't necessarily be like, oh, I can feel a thyroid. In fact, if you can feel a thyroid, that's abnormal. right? For you can imagine there's tissue up against this cartilage, and that's your thyroid, okay? And so the thyroid's main function is setting the basic metabolic rate of the body, right? So heat, temperature, heart rate, energy, all that shit. So that's kind of the idea of that. Now, the parathyroid, para meaning next to, right? So it literally means next to the thyroid. This has to do with calcium and phosphate regulation, and we'll talk about parathyroid hormone. And so we'll talk about this. You see this pathology actually fairly often. It creates people problems that had like thyroid surgery or like there's all sorts of like issues that can happen with thyroid. It's very annoying. And the adrenals. So the adrenals sit on top of the kidneys, so there's like a little like pyramid that sits on top of each kidney, and they look real fatty because there's a lot of fatty substances, hormones that are produced there. And so the adrenals are the main idea of the adrenals is they do two things, right? The first one is they do catecholamines, right? Like epinephrine, which is adrenaline, norepinephrine, dopamine, right? So they do that, they secrete that. But they also secrete cortisol, aldosterone, some sex hormones like testosterone and estrogen in men and women. It's really just testosterone. I'll take that back. It's just testosterone. So just be aware that the adrenals are like these very, for whatever reason, in emergency medicine, neglected thing that are extremely important. And so the adrenals sit on top of each kidney. So you have two adrenal glands. Okay. The pancreas, I'm going to show you an actual better picture of it, but to me, it always looks like a pistol. I don't know why, but it's shaped like this. And so, like, I just imagine like that's a pistol, and like. So, but anyways, this is the pancreas, and over here would be the spleen, actually. And sitting on top of this is like the stomach. And so it's mostly covered, and you can see that in their drawing here, right? This is like a little piece of the pancreas, but if I were to draw this out for you, it goes like this way. Okay, don't get silly with what that looks like. Now, we'll keep going. The stomach does produce some endocrine hormones, but not significant, but it does. It has to do with like satiety and like, which satiety is the feeling of being full and hunger and stuff like that, like ghrelin and leptin and stuff like that. Those are the hormones. Now, the duodenum, they're showing you that the pancreas will have a duct that will dump into the duodenum. So, in the stomach, obviously dumps stuff into the duodenum as well. Now, in females, we have the ovaries, right? These are like the equivalents of a male's testicle. They're inside the body. They're from the same embryologic tissue. And so this is where eggs are stored. There is a tremendous amount of hormone that is produced here during ovulation. So like estrogen, progesterone, those things are produced in the ovaries. So this is why at menopause, this goes away, and then women have less hormone. And so that's pretty intuitive. And with men, what is the male's main sex hormone? It's testosterone. And so the testosterone is produced in the testicles of men. So is sperm as well, but testosterone, as far as endocrine goes, is testosterone you need to know about. Okay, and in older men that decreases as well, just like older women when they reach menopause. Now, this is jumping into the pituitary gland. So this does a lot of things, and this picture is a pretty good picture actually, because it shows kind of what all it creates. And so we'll just do, I think it's easier to start with the posterior pituitary, which is back here, right? So what happens is there's these neurosecretory cells will send a signal down into the posterior pituitary. And it tells it like, hey, generate hormones. So the hormone itself is actually actually it's not, it's generated in the hypothalamus, and then it travels down into the posterior pituitary. And so that's kind of the general rule of that. And so like prolactin and oxytocin are some of the main ones that are produced back there. Actually, why am I getting this confused? I'm sorry, guys. It's oxytocin and antidiuretic hormone are produced in the posterior pituitary, or stored in the posterior pituitary. And so, oxytocin is like the hormone of bonding. So this will stimulate, mainly what we know as paramedics is that it stimulates uterine contraction. So in pregnancy, this is one of the few examples of positive feedback in the body, where the body gets a little bit of oxytocin, then it wants more and more and more and more. And then this causes the uterus, which is the muscle that's holding the baby, to squeeze, and it squeezes the baby out. So that's the example of oxytocin. It also has to do with milk letdown, to where it'll help milk to be let down to begin lactation. Now, antidiuretic hormone, if you break down what this means, this word right here, it literally means anti, meaning don't. Diurese means to pee, okay? So don't pee hormone, antidiuretic hormone, it will help you hold on to water. So if you have an increase in antidiuretic hormone, you're going to hold on to water. If you have it, and if you have too much, that's called diabetes insipidus. If you have a decreased, or I'm getting these backwards. I'm sorry. If you have too much antidiuretic hormone, that is called SIADH, syndrome of inappropriate antidiuretic hormone, and you'll be holding too much water. If you have not enough antidiuretic hormone, then you can end up urinating a lot, right? And so, there's two types of diabetes. There's diabetes mellitus, which is the blood sugar one we're going to talk about, and then there's diabetes insipidus. This one is talking about diabetes insipidus, is talking about antidiuretic hormone. Now, some of these other ones that are produced in the anterior pituitary, prolactin, again, this has to do with, it literally means pro, as in to promote lactation. It's going to promote milk production, okay? Melanocyte stimulating hormone. This tells melanocytes within the skin to produce pigment, right? Growth hormone, pretty obvious. It tells bones and muscles to grow. Thyroid stimulating hormone. This is a hormone that goes down to your thyroid and screams at your thyroid to produce hormone in the form of thyroglobulin, T3, T4, right? And then adrenocorticotropic hormone. You have an absence of this or issues with this in Addison's disease. And so this tells the adrenal cortex, remember the little pyramid guy that sits on top of the kidney, to produce a hormone that has to do with water regulation and blood pressure regulation within the body. And then these are the main sex ones. These are called gonadotropic hormones. And so they're FSH and LH. So FSH is follicular stimulating hormone, and LH is luteinizing hormone. They both act on the testes and ovaries in different ways. It's not really important how, but obviously for women, it's kind of important to know that this has to do with ovulation. And so when a woman gets her period every 28 days, presumably, these are the two hormones that are making shifts to change the amount of estrogen and progesterone in the blood, or to allow the receptors to regulate on that. So it's confusing, but just know that the pituitary is a very important um, uh, part of the endocrine system. So the thyroid gland, like I said, it sits up here. You really shouldn't feel it. You'll feel it if there's like a nodule or something, but it's kind of meaty. If you've ever done, well, I mean, you probably haven't. If you ever do like a cadaver lab or like a pig trachea, you can feel it. It's meaty, and so very rich in blood supply. That's something to know. But the thyroid gland secretes thyroxine, which is T3 or T4, and then it will be converted to T3. But basically, this is what sets the body's, what's called the body's basic metabolic rate. So if you ever heard someone like, oh, the fast metabolism, right? It kind of could, you could almost relate that to like, oh, so they can like burn through food really quickly and not gain a lot of weight, and they're always hot, so they could have hot heat intolerance and high heart rate and all these other things. But this in homeostasis, right? This is where we're normally supposed to be. But you can have hyperthyroidism, which is when you have too much of this thyroid stuff floating around in your blood, or you can have hypothyroidism, which is probably more common, which is when you have not enough thyroid stuff floating around in your blood. And this is treatable. The patient will take a medicine called levothyroxine, and it's very common. If you run an ambulance shift, you will see this on someone's med list. Very, very common medication. So the thyroid also secretes something called calcitonin, and you're like, "What, Hunter? You just said that the parathyroid does calcium." Well, it does, but it's sampled by the thyroid itself. So the thyroid secretes this stuff called calcitonin, which helps maintain the normal calcium levels in the blood, and that's really all you need to know. But the weird thing about this is it's not calcitonin is secreted by the thyroid gland, not the parathyroid gland. It's kind of weird, and so sometimes it's tested for that reason because it's weird. Now, the pancreas, I told you. Let me see. This is a better picture. Um, it looks like a gun, kind of, and so the pancreas. Let me start with this. It sits behind the stomach. It sits so right about here on you, and so it is both an endocrine and exocrine organ. What does that mean? Endocrine mean it dumps stuff directly into blood vessels. Okay, endocrine means it dumps stuff directly into blood vessels. It's not ducted. And it also has an exocrine function, which means that it travels through ducts. And so the pancreas, as we know, produces insulin and glucagon and somatostatin, but it also produces a stuff called amylase and lipase that breaks down carbohydrates and fat, respectively. And so what happens is these digestive enzymes that are produced by the pancreas travel down these ducts through a ducted system, and they'll dump into the duodenum. when there's food there, and so it'll break down fat and carbohydrates. And so this is the weird thing about the pancreas is like, oh, well, it's both endocrine and exocrine. It sits both in the peritoneum and in the retroperitoneum. The tail of the pancreas is in the retroperitoneum. And so it's kind of this weird organ, but I mean, that's kind of the important part of it. So we'll see what they have to say. I just want to draw that out for, and that's what I was saying right here. It's considered both an endocrine gland and an exocrine gland. So the exocrine components, these are like enzymes like lipase and amylase. And so these dump into the duodenum, the first part of the intestine, right after the stomach, and they'll mix with the food to help digest it. And then the endocrine components are producing these little cells called the islets of Langerhans. And so these are where, in this, what they're showing you here, right here. And so this is where it'll produce like insulin and glucagon. And so, you could guess these are endocrine. And what are these guys? They're connected directly to a duct. They're exocrine, right? So because they're connected to a duct. So exocrine is connected to a duct, and then in this case, they're producing amylase and lipase. And a few other things, but those are the main ones. Now, glucose is the major source of energy for the body. That's no surprise at this point of the course, but without glucose, your whole body will start to suffer. But one of the first places you'll see that, and the most notable places you'll see that, is in the brain. And so you'll get like altered mental status, and these patients can get permanent brain damage because the brain is it's in shock, right? It's not getting what it needs to perfuse. So you'll end up with like altered mental status is like a hallmark of too low of low blood sugar, and we'll talk about that some more. But that's important to know. But the body produces a stuff called glucagon in the pancreas that will raise the blood sugar when it's low. So we store glucose in the form of chains called glycogen in our muscle and our livers. And so when your blood sugar gets low, say it's been like 12 hours since you last ate, or even in the morning, right? You're already fasting if you've been asleep for 10 hours or whatever. Your body will start releasing glucagon to tell your body, hey, release the glycogen, which is, remember, just sugars on a chain. And so then your body can use those sugars on a chain, chop them up, and then use it for energy. And that's a pretty common occurrence. And why I'm explaining this to you is because we carry glucagon on the ambulance, right? And there are some states, Texas being one of them, that will occasionally let EMT basics give glucagon because it can save a diabetic's life because you can't start IVs. But you can put a needle into their arm and just inject them like a flu shot, and within 15 minutes they should wake up when their blood sugar stabilizes. So that's why I'm explaining that. Now, insulin is needed to allow glucose to enter the individual cells to fuel their function. So, this is something that I think eludes students for a long time. So let me just draw this out for you real quick. So this is sugar, right? And so this is a cell, right? And so what happens is sugar can't just come into this cell. What has to happen is you have to have insulin that will bind and force sugar into the cell. And so insulin is literally like the key that unlocks the cellular door to allow sugar to enter. Okay? And so you can have all the sugar in the world floating around in the bloodstream. If you don't have insulin, it doesn't matter because the cells will not be able to uptake that insulin. So your brain cells, even though they're surrounded in sugar, cannot let the sugar into the cell to do its job. And so this is why we have to have insulin. And so, diabetes, there's lack of insulin. Type 1 diabetes, there's lack of insulin. So, the patient will inject insulin several times a day to facilitate this. And, a type 1 diabetic that's decided to stop taking their insulin will only live a couple days. It's because it's that important. Now, when blood glucose levels are elevated, so the insulin production will increase. And so this is what I just talked about. Insulin increases cell membrane permeability and mediate the transport of glucose across the cell membrane into the cell. So remember, insulin is that little key that unlocks the cell and it grabs the sugar and throws it in the cell and closes the door. And so that is the important part to know what insulin does. So when the blood glucose levels decrease, there's this stuff called glucagon. So I was explaining this earlier. Glucagon is a hormone that is produced in the pancreas. And so what it does is it raises the blood glucose level by telling the liver, and really the liver, to release glycogen, which, remember, glycogen is just like a chain of sugars. And so when glycogen comes out, it'll just be like chop, 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 and it'll just chop it up into where the glucose can go out into the bloodstream. Okay? Now, endocrine disorders, I've alluded to this, can be from hypersecretion or hyposecretion or insufficient secretion of the gland, or the gland is absent, or the gland is damaged, or it's scarred, or it's not responding, whatever the scenario is. But it's usually where we get these endocrine emergencies is too much or too little. Obviously, we don't get calls for just the right amount, but just be aware that there's both hypersecretion and hyposecretion. And so what you see a lot in these disorders is the word back to medical terminology, hyperthyroidism means there's too much thyroid stuff going on. And then hypothyroidism means there's not enough thyroid stuff going on. So that's kind of an important concept you'll see, because you can see like hypogonadism and hypoaldosteronism and hyperaldosteronism and like all these things. And so again, I'm a big fan of medical terminology. If you get lost, just look at the word, and you can usually figure out, piece together the word through medical terminology. Now we're going to jump into diabetes mellitus. So, I said there's really two main forms of diabetes we should know about. There's diabetes insipidus, that's where there's a head injury usually, and they'll pee too much, okay? But diabetes mellitus is when they pee too much, but the urine tends to be sweet. In fact, a long time ago, doctors used to stick their fingers in patients' urine and taste it, and if it tasted sweet, that was how diabetes was diagnosed, right? So this is like what it's like diabetes mellitus means like sweet urine. And so this is kind of where this came from. Now, so we'll talk about, let me start with this. Diabetes is very common. If you work a 12-hour shift in like MedStar or Life Care, you will run a diabetic. I guarantee it. So you run into this a lot, okay? So just be aware. This is not us being fancy. You will encounter this almost every shift of your career, okay? Now, there's type 1 and there's type 2 diabetes, and I know that can sound overwhelming, but we're going to break it down, and I have a chart at the end to hopefully explain it. So let's just talk about what, in general, before we jump into the types, what is diabetes, right? So diabetes mellitus, and moving forward, I'm just going to refer to it as diabetes. Sometimes, though, let me tell you, you'll see it written DM, not like direct messaging, but like a DM, okay? And so diabetes is a metabolic disorder associated with a complex disease with many causes. And so exactly how diabetes happens kind of varies, okay? But the end result is you have high blood sugar, okay? High, glyce, so referring to a sugar, emia in the blood. High sugar in the blood, hyperglycemia. What's the normal blood glucose level? It's supposed to be like somewhere between 80 and 120. It depends on the book you read. Some might say like 70 and 120, okay? But it just varies, okay? Somewhere in there is around normal. Now, what happens is you have to think about this. You have too much glucose floating around in your blood. What happens is glucose is it has an osmotic pull. So when you have so the normal is like 120, right, of milligrams deciliter in the blood, right? This is of sugar. And so what happens if someone has a blood glucose of 500, right? Like 5 times the normal, 4 times the normal, right? What happens is your body will start dumping water into the vasculature because it has an osmotic pull. Remember, water follows salt? Well, water follows sugar as well. It has the same pull. And so the issue is you start pulling water into the vasculature, and because of that, you get what's called the polys, right? And so you can get polyphagia, which is eating too much, right? To phage is to eat. So that means eating too much. You can get polydipsia, which is to drink too much. And then you get polyuria, which is to urinate too much. So they eat too much, they drink too much, and they pee too much. And this is because the blood sugar in their blood is very high. And so they're dumping all their water through their urine. So they're like, oh my God, I'm thirsty. And they're thirsty. So they drink more water, and it makes the urination issue worse. And then on top of all that, the cells are still starving for energy because they're not getting it. Look, there's tons of glucose floating around in the blood here, but since there's not enough insulin, or there's insulin resistance, whatever the story is, the cells can't uptake that insulin. So it creates this problem for the patient that we're like, wow, they have all this sugar and they can't get it into the cell. So what they'll do is they'll eat a lot, okay? And so the classic diabetic that hasn't been diagnosed yet is like a kid, like pubescent kid or before, that has that's like really skinny, because their body is like taking in all this food, but it's not really going into the cells or the fat or anything like that. It's just floating around. So that's something to know. The and this will show up on a test, I promise. Polyphagia, polydipsia, and polyuria. Polyphagia means to eat too much, polydipsia means to drink too much, and polyuria means to urinate too much. Okay? Now, the consequence of diabetes, of having this high blood sugar, is bad. Okay, and so in paramedic school, like I have my students say, like, "Wow, you must not like diabetics." Well, that's not true, because what I'm saying is when I teach pathology, I'm like, "Oh, diabetics have this, diabetics have that, diabetics have this," because they have all these pathologies if they don't take care of their diabetes. So what happens is it's a systemic issue, right? There's blood that goes all across your body, so your whole body gets jacked up if you don't take care of your blood sugar and have diabetes. So you have over a period of time, these patients will end up with a decreased kidney function, and so their kidneys kind of get jacked up from too much blood sugar. Let's just and too much protein in the blood as well, and so it jacks up the kidneys. Okay, so if you were to walk into a dialysis center and say, "What are you doing time for? Why are you here on a Monday, Wednesday, Friday for 4 hours at a time?" They're going to tell you diabetes, 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 high blood pressure, diabetes, and high blood pressure. Right? Usually, that's almost always why all those patients are there. Right? Diabetes and high blood sugar, or I'm sorry, diabetes and high blood pressure, hypertension. And so you have to realize if, and I'll come into this. The next thing is you can get what's called atherosclerosis and arteriolosclerosis mainly. And so this is hardening and stiffening of the blood vessels, one, and then two, that can lead to plaque formation, okay? So the blood vessels that are normally like nice and fairly squishy water hoses become hard like PVC pipes. And so this creates all sorts of issues for the patients, and it's easier for plaque to build up on there, and then you can get a clot. And so that's one thing to notice as well. So because of what I just described, you're at a much, 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 much higher risk of a cerebrovascular accident, or CVA, also known as a stroke, right? To where when a vessel in the head or the neck gets destroyed and it bleeds or it gets blocked off or whatever, and that creates stroke-like symptoms. So talk about that. We've talked about that actually in neurology. And hypertension, again, these vessels are no longer squishy like water hoses. They're hard like PVC pipes, so that creates an issue. And then peripheral artery disease, that's what they're showing you here, kinda. Yeah, not, I mean, it's in the greatest example, but peripheral artery disease is when the arteries going to your periphery, in this case, like, for example, your legs, get blocked up, and stiff, and so then you get decreased blood flow down to your, like your feet and stuff. So it's not uncommon for diabetics to end up losing feet, or losing feet and toes because of decreased blood flow. And because of that, they also get decreased wound healing. And then the last one is this thing called neuropathy, right? It's neuropathy. And so this is where the nerves get damaged because of the high blood sugar. One, creates an osmotic injury. Also because of the decreased blood flow to the nerves. So remember, nerves require a lot of blood flow. Well, I'm just described everything above this sounds like a blood vessel issue. So of course they're not going to get enough, and then that creates all these problems. So, if I could recapitulate, this is very important, like a one-liner that you need to know. If there is one thing that diabetes itself will cause, it is vascular disease. Okay, so the vessels become damaged, they become weak, they become injured. So all these issues can be tied back to vascular disease. And so that's that. So kidney function, it's a vascular issue. The vessels within the kidneys were damaged. That's why this happens. Atherosclerosis, coronary artery disease, vessel issue. The vessels have been damaged. Stroke, hypertension, peripheral artery disease. The vessels have been damaged. Neuropathy, the vessels have been damaged. So this is what happens. And so it's not uncommon. Imagine a diabetic who has neuropathy, so they can't feel their feet, or they can't feel them very well, who has poor blood flow to their feet, and then they accidentally kick a chair, right? So they injure their foot, but there's not good blood flow because they have peripheral artery disease. So then it doesn't heal. So diabetics have this thing called delayed wound healing. And so their wounds get all jacked up. So it takes forever to heal if they ever heal. And if they don't heal, they get gangrene. And then we have to go in there and chop off their foot or chop off their toes. And so it's just this huge issue. That's why it's very important to control diabetes and prevent this. This is all preventable, right? If you control your diabetes, you could prevent almost all of this. Now, diabetes mellitus, there's both chronic and acute complications with this. We tend to focus a little bit more on the acute ones in EMS. But, again, if you don't treat this, you're going to live for a couple days, maybe a little longer than that. It depends on how severe, before you'll just die. So, these patients will take medicine until the day they die, because if not, they're going to die. So this table, I got out of a textbook that's probably a little advanced for EMT school, but I like it. I like tables that are pretty succinct and like to the point. And so over here, we have type 1 diabetes and type 2. So let me just draw these out for you. Let's focus over here for now, type 1, right? So type 1 diabetes is also occasionally called juvenile diabetes. And so juvenile diabetes means it happens in kids. And so we don't know exactly how or why. If we did know, we would solve it. But what we do know is that for whatever reason, the body decides to attack. This is an autoimmune condition. So the body attacks itself, and one of the places it attacks it is in the endocrine pancreas. And so the endocrine pancreas gets attacked by the body. This tends to manifest itself in childhood, okay? Almost always. For textbook purposes, almost always. And so or young adulthood. And so what happens is when these cells get attacked, they get so attacked they get destroyed and they can't regenerate. So you end up with no insulin that's being produced by the pancreas. So these are the patients that have to take insulin. And so, they almost always have to take insulin. Generally they're going to be less than 30 years old. They're usually not obese. They're usually skinny, right? It's a fairly weak genetic predisposition. You don't need to know that really. You probably don't need to know the rest of this, but except this one. These are the ones where you're going to see the polyuria, polydipsia, polyphagia, weight loss. Okay. Now, if they give you a vignette, 10-year-old girl, she's been drinking a lot of water, she's been eating a lot, she's been losing a lot of weight. So she named off the polys, right? So you would think like, okay, well, they're probably trying to push me to think this is type 1 diabetes, okay? So the answer is you can check your blood glucose, and EMTs can do that. And we'll talk about how you do that, but you stick a little needle in their finger and sample it, and it'll immediately tell you their blood glucose. What's the normal blood glucose level? It's between 80 and 120. And so what happens is that's very common, and you'll see this, you will see this. And so this patient will take insulin until the day they die because their pancreas will never, unless they get a pancreas transplant, which doesn't happen, um, then they'll be like that forever. Now, type 2 diabetes is different. It's much more common. And so what happens is the patient will get obese, okay? Or whatever reason, they eat too much sugar over a lifetime, and the pancreas has been producing a lot of insulin because there's a lot of glucose in the blood, and eventually the cells will become resistant to the insulin, okay, and the glucose. And so it's like, huh? Well, like that same cell, this is the cell. It's gonna need even if there's sugar floating around in the blood, it's gonna need even more insulin. It's gonna have to be connected like 6 times to get it to go into that cell, and then this one's gonna need even more insulin to convince it to go into the cell. And over a lifetime, when you're producing all this insulin, right, your pancreas will burn out. Like it gets burnt out to where it'll kind of like it's like I'm done. I can't do it anymore. And so that's one of the hallmarks. So in a very indirect way, almost like type 1 diabetes, your pancreas will stop producing as much insulin. Okay, so that's one issue with type 2 diabetes. The other one, and the more common one, is decreased or increased cellular resistance to glucose and insulin. And so this is this issue that we face. And so who does this almost always happen to? It's almost always obese people. Okay, it's almost always obese. Okay, it doesn't have to be, but they will. They're usually not skinny. And so this is usually in people in like their fourth, fifth generation of life, right? So this will happen to people in their 40s and 50s after the pancreas is like, oh my God, I've been hanging on for 40 years. I can't do it anymore, right? And the cells have been dealing with all this shenanigans for a long time. And so just be aware. Now, interestingly, there's a huge genetic component to this. So if your parents or brother or sister has this, probably you will too. There's a higher chance of that. Okay. Now whoops. I hate when it does this. Hold on. All right. Let's talk about type 1 diabetes. So type 1 diabetes, you might think like they have to use one insulin, like a syringe, almost like makes a one, to where they have to inject insulin, okay? And so that may help you. Type 1 is the one with the syringe. This looks like a one, where they have to inject insulin, just like this. Okay, that's an auto injector, like one of the more fancy ones. And so this is insulin-dependent diabetes, has a hereditary disposition, but it's probably more environmental. Like people get a virus for whatever reason, and then their body gets confused through molecular mimicry and it attacks itself. So they have to do daily insulin injections and strict dietary control in order to survive. Okay. So this is what's called an insulin pump. These are becoming more and more important or common and important in 2024 because what happens is there's a little itty bitty needle that goes up underneath the skin that's constantly it's traveled by a tube. You can see the tube right there. That's constantly sampling the blood glucose that's sending feedback to the pump or in this day to the phone. And so it'll send data there and say like, oh, hey, your blood sugar is too high. We need to increase the insulin. And so the machine will automatically inject insulin or that you can override it with your phone or the device or whatever. And so these are really pretty cool. It's just important to know these exist, and these are pretty common at this point. Now, type 2 diabetes mellitus, this is generally later in life. The blood glucose levels are generally elevated, like in the 200s, 180s, whatever. And so it's generally in the middle of life, right, where this will occur. And so if you don't treat this, you'll get the same symptoms, but in general, these patients will complain of vague stuff like fatigue, nausea, frequent urination, thirst. Again, their sugar's high, so they're dumping all that water into their blood, so then they're peeing it out. And there's another reason that happens too, but we'll go with that. And so, unexplained weight loss, blurred vision, slow healing of wounds. Remember, delayed healing is a hallmark of diabetes. This becomes an issue when people get little bitty wounds. It takes forever for it to heal because of the poor blood flow. And in extreme cases, they could have unresponsiveness and seizure. Now, these are blood glucose monitors. We'll go over this in class. We'll let you check your glucose if you want, or check colleagues, or we'll do it on a mannequin. But basically, what happens is you put a little alcohol on the finger and you'll poke it with what's called a lancet. It's like a little spring-loaded needle. And then you'll squeeze out capillary blood from the capillary tips. That's this blood right here. And then you'll stick this little test meter on there. It sucks up like an itty bitty drop of blood. And within like 5 seconds, it'll shoot out a number. That's different. That's in millimoles. That's what they use in Canada. In the United States, we use milligrams per deciliter. So again, the normal is like between 80 and 120. Now, weight loss is a very important treatment in type 2 diabetes, but this is the United States of America. It's hard to do weight loss. So what we do more often is we'll prescribe medications like metformin. You've probably heard of these Hollywood drugs like Ozempic, Wegovy, Mounjaro, Victoza, all those guys. Those are generally originally treated or they're originally designed to treat type 2 diabetes, but they also help promote weight loss. And I think they're great drugs. I think they're the greatest drugs of this decade, actually. And so they'll save more lives pound for pound than any other drug on the market, I think. And so, because they help people lose weight. And so just be aware those exist. We'll talk about how to do this in class. You do this very often, by the way. We'll also talk about how to pull it from an IV catheter. So like if your paramedic partner starts an IV, we'll talk about how can you get the blood out of that to test it. That's very common. Pretty much every time I start an IV, I'll test their blood glucose. Okay? So we test blood glucose on people that are like have an altered mental status. Anybody that has an altered mental status, you have to check their glucose. Standard of care. It's negligent not to. Now, pre-diabetes, this is very common in the United States. I think like 40 or 45% of the United States has pre-diabetes. And so this is when you have a fairly elevated level of blood glucose, but it's not full-blown type 2 diabetes yet. And so what happens is you'll go to the doctor's office and they'll draw your blood, venous blood, and they'll say, oh, your hemoglobin A1C is 7.2 or whatever. And so it should be less than like 6.5, and so, or 5.5 ideally. And so what happens is a hemoglobin is a red blood cell, but this certain one, this A1C guy, we found out that it really likes to grow in sugary environments. So if there's a lot of sugar floating around in your blood, it'll glycosylate and it'll keep growing and growing and growing and growing. And so it'll multiply. It doesn't really grow, it multiplies. And so as it multiplies, we can measure that in your blood and be like, oh, wow, your blood sugar has been really high over the past 3 months, 4 months, because your hemoglobin A1C is high. And so we use this test as an average of blood glucose in the clinic. So you've probably heard of this before. It's a lot simpler than what people think. It's essentially a red blood cell that likes to grow in sugary environments. Now, again, people that are older are at a high risk of prediabetes, being overweight, and a family history of diabetes. Okay. Losing 5 to 7% of your body weight and getting at least 150 minutes of physical activity per week can prevent or delay the onset. This is where, diet and exercise become very, very important as we age. Now, gestational diabetes, you've probably heard of this, maybe you haven't. We'll talk about it quite a bit more in our obstetric chapter. But basically, the pregnancy chapter, basically, what happens is when the woman is pregnant, she'll produce a hormone, which you know the name, but it's called HPL. And so what happens is the mom's, there's the placenta here, right? And so what happens is this is the mom's side, this is the baby side. Glucose has to go back and forth in this. Well, what happens is the mom's like, you know what? I'm going to raise my blood glucose level so it's easier for glucose to go back and forth the placenta to the baby. And so they release this hormone called HPL, which will increase the amount of blood glucose in your blood. And this is by design. It's supposed to happen in pregnancy, but what's not supposed to happen is when it increases too much, because then you get a really big baby. And if you get a really big baby, you have to have a C-section or deliver them early. And so this is why women will do glucose tolerance testing in pregnancy, is to hopefully catch this and treat it. Usually just diet modification and exercise is enough to fix this. Sometimes you have the physician will do medicine, but you have to, one thing I'll say about gestational diabetes, you should know if you have a mom that tells you, oh, I have gestational diabetes, you need to be thinking big baby. They're going to have a big baby. So what does that mean? They're probably not going to be able to squeeze that through their pelvis and their vaginal vault. And so it may end up being a C-section. Now, hypoglycemia is going to be a blood glucose generally less than 70. And so, and the unit of measurement on this is milligrams per deciliter. And so, what happens is, it's can be the result of taking too much insulin. So think about this: the patient accidentally pushes, instead of 10 units of insulin, 100 units of insulin, right? That's too much insulin. So all the glucose in the blood is going to get shoved into cells, so it's going to drop. The blood glucose will drop. So that's one way this can happen. Another way, a more common way this can happen, is they don't eat enough food, right? So someone doesn't eat enough food, they're like, oh, my sugar feels low, they'll feel weak, clammy, and then or both. And in diabetics, actually, I'll be honest, it's probably usually a combination of both. What happens is they'll inject their normal dose of insulin, and they're like, oh, I'm going to eat, and then they don't eat. They go to watch a football game or go to the store or start talking on the phone, and their sugar drops and they're unconscious, and we get called to come help them. So it's very common that that's how that happens, like a scenario like that, where they take their insulin, they forget to eat. And so, and you're like, oh, wow, they forget to eat. And I'm like, well, it doesn't happen that often, but I mean, if it happens once a shift, that's a lot. There's a lot of diabetics out there. Now, the counterregulation is the body's natural defensive ability to maintain blood glucose. Remember, the first line of defense is reduce insulin production. Okay, the second one is a secretion of catecholamines. What are catecholamines? Norepinephrine, epinephrine, dopamine. Epinephrine is adrenaline. By the adrenal gland. Where's the adrenal gland? Sits on top of the kidneys, right? Little pyramid thing, fatty looking thing sitting on top of the kidney. Okay, and so again, in hypoglycemia, in patients with type 1 diabetes, the islets and Langerhans do not produce insulin. So what's happened when the blood sugar drops too low is they've injected too much insulin, and that's what's caused that. And in type 2 diabetes, the pancreas will usually, up until the very end, produce insulin, but usually what's more so common is that they just didn't eat. And so patients will experience trembling. That's very common. They get real trembly, a rapid heart rate, rapid shallow respiration, sweating, and feeling of hunger. So there's a saying in the old country that I want you to write down, right? If they're, I'm not kidding, write this down. Cool and clammy, give them jammy, right? That means their sugar's low. Okay? Cool and clammy, give them jammy. If they're hot and dry, they's sugars high. All right, if they're cool and clammy, give them jammy. If they're hot and dry, their sugar's high. So this is important to note in all seriousness for what we're talking about, hypoglycemia. You will see when you see someone, if you see this once, you will never forget it, and you'll see it often. It's called diaphoresis. Diaphoresis is the medical word for sweating. And so when you walk in and it's like, 70 degrees outside and the patient's just pouring this slimy, gross sweat, that's called diaphoresis. Your first clue should be they're in shock. I bet that shock is due to low blood sugar. And so you would check their blood glucose and boom, 20. It's 20. It's supposed to be between 80 and 120. So then you got to do something about it. Okay. Now, we're going to talk about hyperglycemia coming up. And so we'll talk about what that means. Okay. And so hyperglycemia and diabetic ketoacidosis occur. So that's the next portion. Okay. And so I cannot stress enough, you will see this. If someone is sweaty and tremulous, altered mental status, weak, uh, stuttered speech, you need to think, oh wow, they're in shock. That shock is likely due to hypoglycemia. We need to do something. They're about to be unconscious if they're not already. And so there's these things called hyperglycemia. Hyperglycemia is high blood sugar, and diabetic ketoacidosis. And we'll talk about this. This gets very complicated, but I'm hoping to make it simple. And so basically, hyperglycemia makes sense. It's when the blood sugar's high. It's greater than 120. Okay, it can be 200. It can be 1,000. Doesn't matter. It's high. Okay, and so a hyperglycemic crisis is the state of unresponsiveness resulting from several different problems. This is more rare. Let me say that. If someone's unconscious related to a blood sugar issue, it's more likely that it's due to low blood sugar. Low blood sugar, you will become unconscious a lot quicker within a matter of minutes, hours, an hour. Versus if someone has high blood sugar, it usually takes a day or two before they fully reach unconscious state. It's a lot more rare. So I want you to distinguish the differentiation between that. When you run a diabetic low blood sugar and they're all cool and clammy and they're usually unresponsive, okay? That's very common. Now, there's this thing called diabetic ketoacidosis, okay? And so what this is when your body has no insulin, because this happens in type 1 diabetes. Your body has no insulin, and so your body will switch to, instead of burning glucose for energy, it'll start burning fat and proteins. Fat, really. And so if you ever heard of the keto diet, it's the same thing. And so what happens is you don't eat sugar and carbs in the keto diet, you eat a lot of fat. And so when you eat a lot of fat, your body will burn that for energy. And so in diabetic ketoacidosis, what happens is the patient isn't taking their insulin, so it can't push that glucose into the cells. So the body goes into panic mode. It's like, fine, we'll just burn fat. So it starts burning fat. Well, when it burns fat, it produces these things called ketones. And so what happens is these ketones are in themselves are acidic. Like the most common one that we'll see is called beta hydroxybutyric acid. And so the words acid is in the name of these ketones, like ketosis, right? The ketoacidosis. And so what happens is you have this buildup of acidic stuff, ketones, right, in the body. And so what happens is this creates all sorts of issues for the patient. And so I'll talk about how to differentiate this. But you're asking yourself, well, who gets DKA? Well, first off, it's almost always type 1 diabetics, but it's usually when they have like some type of stressor, right? So like that could be infection, like a UTI or a skin infection or injury. They got hit with a car. Alcohol use, they're drinking too much alcohol. Emotional distress, their boyfriend just broke up with them, right? Illness such as stroke or myocardial infarction, right? So some type of stress has been placed on the body, and then they'll go into DKA, okay? Now, the same thing, these polys show up because, again, DKA is related to type 1 diabetes. So are the polys, type 1 diabetes. So this shows you over here, right? Like the normal is somewhere between 80 and 120, okay? 80 and 120. But hyperglycemia is like somewhere between it's really up above 120. But the diabetic ketoacidosis range is somewhere between 250 and about 600. And so if they tell you in the vignette the patient's blood sugar is 400 and they're peeing a lot and drinking a lot and eating a lot and their blood sugar is 400, you'd be like, okay, it sounds like DKA. Okay. They'll also present with something called Kussmaul respirations, which I'll talk about. Okay. And so the hallmark of this, of how do you treat diabetic ketoacidosis, is you would think, well, you need to lower the blood sugar. You need to give them insulin. Well, you do, but that's done in ICU over a period of days, okay? One. Two, the main treatment is actually to give them a lot of fluid, lots of IV fluids. Because remember, they're dry. Their blood sugar's been really high, so they've been losing all their water. So usually it's like liters, like 4 or 5 of these the patient will get over a period of time because they're that dehydrated. And so that's really the main treatment. Now, proper fluid rehydration, insulin are not given, ketoacidosis will progress to unresponsive diabetic coma and eventually death. Now, there's this word that I'm surprised these slides did not mention called Kussmaul respirations. And so, Hunter, what are Kussmaul respirations? Well, it is this stuff called when the patient breathes really deep and really fast. And so I can induce Kussmaul respirations on you right now. I would tell you, student, I will give you 100 in this course if you can run to the stop sign and back in less than 30 seconds. I don't know. And so you'd run as fast as you can, and your body would be working really hard, and you'd come back and you'd be huffing and puffing. And what do you do when you're huffing and puffing? You're taking deep breaths in and deep breaths out, and deep breaths in and deep breaths out. Well, that's called Kussmaul respirations. It's named after a dude, okay? And so what happens is you see this form of respirations in diabetic ketoacidosis. Because if you'll remember way back to our pathophysiology lectures, I told you about this thing called metabolic acidosis. Acidosis. And so what happens is the patient will be in metabolic acidosis because they have a buildup of all these ketones in their blood. And so they'll be breathing really fast, really hard, really deep to try to blow off that CO2, which is also acidic, to try to get rid of something that's acidic to balance the pH of the blood. What's the normal pH of the blood? 7.35 to 7.45. And so they'll be breathing like 28 times a minute, really deep. So watch for that in vignettes. They'll say the patient is breathing rapid and deep, right? They're describing Kussmaul respirations. And so you need to be very mindful of that. It's because they're in metabolic acidosis and they're trying to blow off CO2, which is also acidic. And so one other thing I'll say about this is these ketones produce acetone, okay? And so acetone can be actually excreted in the lungs. And so they'll have what's called, watch for this in vignettes, a fruity odor on their breath. Their breath smells like fruit, okay? Only about half the population can smell this. My mom's one of them. She can smell it like that. And so they produce this like, it's acetone, right? It's coming out from their lungs through their mouth when they're talking and breathing. And so it's this very distinct smell called a fruity odor on the breath. And this is related to someone who's in ketosis, okay? So it's usually type 1 diabetics who are in diabetic ketoacidosis. Diabetic ketoacidosis is incredibly lethal, right? If this is untreated, they're going to die within a day, okay? Their kidneys are getting wrecked out, their brain, everything's getting wrecked out when it's really high like that. So this is an ICU admission usually. Usually they stay in the ICU for a few days. Now, that's the whole type 1 diabetes, high blood sugar stuff. Let's talk about type 2 diabetes. Well, there's this really weird word, right? It's very long, called hyperosmolar, hyperglycemic, non-ketotic syndrome, or it's called HHNK. Or HHNS, I've heard it called different things. And so basically, this is a disorder of type 2 diabetes. Say that again, HHNK, HHNS is a disorder of type 2 diabetes. You need to know that. It is characterized by hyperglycemia, hyperosmolarity, and we'll talk about what that means, and an absence of substantial ketosis. And so these patients still have high blood sugar, so they get that hyperosmolarity where they're dumping sugar or they're dumping water into their blood that gets peed out in their urine. Okay, and so they end up being really dry. And so the signs and symptoms of this HHNS is hyperglycemia. The brain requires glucose, so they can have seizures, partial paralysis, altered mental status, drowsiness, lethargy. Those are all neurosymptoms, right? Because it requires the right amount of sugar. Severe dehydration, thirst, and dark urine. And so what's the normal blood sugar on these? It's usually 600 plus. So if they tell you the patient takes metformin, which is a pill for type 2 diabetes, she's 55 years old, she's had diabetes for 5 years, late onset, and an adult, then you would be like, oh, this sounds like HHNS, right? And so they tell you sugar is 950. It's really high, right? It's like 8 times the normal. Then you'd be like, oh, this is HHNS, okay? Now, can DKA get a 950 glucose? It can. It's just not common, but it can happen. So you can't weigh your hat too heavily on the glucose levels. I'm just giving you a generality. It doesn't take much to push someone into DKA, but generally when we catch HHNS where it creates enough symptoms for them to manifest to the ambulance or the emergency department, it's like 600 or more, their blood sugar. And so this table splits it into two for you. I hope it helps, but let's talk about it. So it's the diabetic ketoacidosis, okay? This is usually from insulin noncompliance or from an increase in stress. And what happens is your body starts doing lipolysis, where it starts using fat for energy, and then you end up with all these ketone bodies. Remember beta hydroxybutyrate, right? And so your body will start using these ketones for energy. Okay, and DKA is deadly. So here's the signs and symptoms. It's deadly, right? Delirium and psychosis, so altered mental status. Kussmaul respiration, so that's that rapid deep breathing I was describing. Abdominal pain, nausea, vomiting, dehydration, and they could have that fruity odor on their breath due to the exhaled acetone. You need to know that. Now the labs, they're going to have high blood sugar. That's forget about the rest. Okay, this is life threatening. Okay, it has to be fixed. Now the other one, HHNS or hyperosmolar hyperglycemic state. Um, it's profound hyperglycemia. It's usually in type 2 diabetes. It's from urinating too much. Usually the blood sugar is more than 600. They could have the polys, the excessive thirst, the polyuria. All right, so neurodeficits. Okay, so that's a table to help kind of differentiate between the two. Um, and this is out of your book. I didn't like this table. You can use it. It's accurate, but I didn't like it. I left it in there. Now, the patient assessment of endocrine emergencies. So it's similar as with any medical patient, right? So we do our scene size up. Be aware, patients that are altered, like diabetics and stuff, they can be really aggressive. We used to always have the sheriff's office have to clear us in for this one guy. It was extremely aggressive every time we got there, and his blood sugar would be low. Um, he only had one hand too. He had like a accident with a crane, so he had like a claw for his hand. And so ensure the personal, that your PPE is ready, right? Question the bystanders. Okay, so these families are probably experts in diabetes, right? So, oh, did they take their insulin? Did they eat? Well, oh, did they take their thyroid medicine? Let me see their medicines, right? It's just standard things we would do where we would interview the bystanders and family to gather history. Okay, so you do the patient assessment and you do your assessment, do your primary survey, form your general impression. Remember general impression across the room. Determine their level of consciousness. Are they alert? Are they alert to verbal, pain, or unresponsive? Right? Um, Assess the patient's airway. Remember, in hyperglycemic situations, mainly type 1 diabetics, they'll have that thing called Kussmaul respirations, where it's rapid, deep respirations. Okay. Now, the opposite, hypoglycemic patients can have normal or slow or shallow or rapid respiration. So it's more like unpredictable. But be aware, they could require airway support where you might have to bag them with a BVM or at a minimum put it on a breather on. Okay. Investigate the chief complaint. Chief complaint's an unresponsive patient. Oh, but we know there are diabetics who've been here 5 times this month. Okay, right? Look for physical signs and symptoms. Oh, the house has no food in it, right? Or, oh, they're wearing an insulin monitor, right? They're wearing an insulin pump. Obtain your sample history, signs and symptoms, allergies, medicines, past medical events, last oral intake, events leading up to this. Check for emergency medical identification device. I know a paramedic that has type 2 diabetic tattooed right here on his wrist, but that's an extreme example. Some of them will wear medical jewelry. Okay. We do our secondary assessment. We do on unresponsive patients, you want to do a full head to toe exam. We don't know if they fell or not, right? Did they become unresponsive and fall to the floor or fall in the bathtub or fall? We don't know. Fall into the chair even. So focus on the patient's mental status, try to figure out how alert they are and their ability to swallow. This is important. You'll see why. But you need to make sure the patient can swallow and protect their airways. Someone with low, really, really low or really high blood glucose, they could lose their ability to swallow. So then we have to worry about them choking on their spit or on their vomit or or choking on their tongue or whatever. They can't protect their airway, right? And we remember use a glucometer, and we'll get a blood sugar and also get vital signs, of course. Now, these patients will require reassessment. So again, the airway is a true concern in any unresponsive patient, but especially diabetics, because sometimes they'll vomit. And so if they vomit, it's a huge issue. So this is a good one where you open up the suction, you stick it up underneath their pillow or up underneath their head. In case they do vomit or you feel like you need to suction spit out of their mouth, it's already open and ready. You just put it in there, okay? Document your findings, of course, and you would base the administration of glucose on serial readings. Serial means like in order, like every 5 minutes or whatever, every 10 minutes, you would check the blood glucose to see how it's doing. Okay. So place the position in a position of comfort. If they have an altered mental status, someone's going to want to start an IV. These are sick patients. EMTs don't start IVs, right? But transport the unresponsive patient supine or in the recovery position, and keep the mouth and pharynx suction free of secretions, vomitus, and blood. Again, this is a really good patient to open up the suction and stick it up underneath their head. That way, if they suction, you can immediately stick it in their mouth. Now, how do we fix this, EMTs? Good question. There's this stuff called oral glucose. It looks like this. The lemon flavor is the best flavor. And so it has 15 grams of straight up, like very simple glucose. And so what you do is you would, in a patient who has a blood sugar less than 70, okay, that has an airway intact, that is able to follow commands, as in can speak to you and swallow, okay, you can give them this. How do you give this? It's through what's called, the buccal route, okay? And so you could just put this in the patient's mouth and have them swallow it, okay? That would be oral. But a quicker way to do this is to line the gums. And so if you line the gums, it's very rich in vasculature, and it'll be absorbed very rapidly that way. So when I do this, I'll just line it in the patient's gums or tell them to do that, okay? They probably know, and they'll just stick it in there. And this will raise their blood glucose. So this is called oral glucose. It's 15 grams of oral glucose. So that's the one treatment. What's the hallmark of this? They have to be able to follow commands and swallow. If the vignette tells you they're altered mental status and not following your commands, but they can swallow, do you give it? No. If they tell you they can swallow, they're following your commands, and they're symptomatic hypoglycemia, can you give it? Yes. But you cannot give this to a patient that can't swallow. Why is that? They will choke on it. I mean, think about it. You put sugar in their mouth, so they'll choke on it. Okay? We don't do this, but I left this on here on purpose. We give this stuff in an IV called IV dextrose. It's a very simple sugar, as paramedics and advanced EMTs, okay? And so you have to start an IV, and you push this glucose stuff through the vein, and it works very well, okay? We use this a lot. Now, the problem with this is you have to start an IV. Sometimes these people have bad vessels, right? They have bad vasculature, so it's really hard to get an IV on them sometimes. And then the thing is, if you get a bad vein or the vein blows or ruptures, it's very necrotic. So it'll cause the tissue to rot, to become necrotic. So you don't want that. So you gotta be careful with that. Now, last one. Some places will let EMT basics, not the National Registry, but like in Texas, there's agencies that'll let you do this. So that's why I'm covering it. Where you can administer what's called intramuscular glucagon. Remember, glucagon is a hormone. Write this down. Glucagon is a hormone that is produced in the pancreas. When your blood sugars drop, when you have hypoglycemia, glucagon is released from the pancreas into the blood. And once it's in the blood, it'll travel to the liver and tell the glycogen to be released from the liver. And then when it's released from the liver, it will remember, glycogen is like this. It's sugars in a chain. It chops it up. And so then you have all the regular molecules floating around in the blood. So how do you give this? You give this in typically intramuscular. It's typically in the deltoid. And so how you do it is you'll take like the deltoid, you clean it with alcohol circular motion, and you'll stick the needle. We'll show you to do this in class. You stick a needle in there with a glucagon in it, and you aspirate. So you pull back. And if you pull back and you get blood, you're in a vein. So you need to like stop, because then you're going to get IV. We give this intramuscular. So you would pull out and you'd have to stick them somewhere else. And I've actually had that happen to me once. And so you pull back, there's no blood coming into your syringe, so then you push, right? Pretty simple. But we'll show you how to do this in class. So, DKA, the treatment for this as an EMT basic is to recognize it and to get them to the hospital. You may have to support their airway, but really rehydration is the goal. You're not going to be able to achieve this by giving them water, so do not give them water by mouth. You're better off getting them to the hospital. The problem with giving them water is the risk of vomiting. So I would avoid giving them water. That's not the right answer. Same thing with HH&S, right? Recognize it, stabilize, take them to the hospital. Be careful if the patient fell in DKA or HH&S that you might have to consider spinal trauma if you find them unresponsive. Okay, that you don't know what happened before that, so you might have to consider spinal trauma. We'll stop here, and then the second half of this is hematologic emergencies.